Hello, and welcome to the Resuscitation Improvement course. Please keep in mind that all of the concepts discussed in this course are not implemented yet and are purely for discussion purposes only. We must first get into the mindset of a skilled resuscitationist. When faced with a life or death situation such as cardiac arrest, are you looking at the forest or each individual tree? Focusing on the procedure is only one element of evaluating, executing, and leading a coordinated team effort to resuscitate the patient. In the pre-hospital setting, we are responsible for calling the shots and making sure everything is performed correctly. This starts on the way to the call. If you have been advised of a cardiac arrest, then start discussing it with your partner on the way. We have to have a good game plan, which starts with training and mental preparation. We have to have good communication on scene and en route to the call. We need to execute properly. We need to make sure that our actions are getting the desired results. And we have to evaluate. This is an ongoing process. We have to make sure what we do on a regular basis is working. Common sense will tell us not to treat the numbers on the monitor, but to treat the patient. This needs to be updated to treat the patient and the monitor. With tools like pulse oximetry and end-tidal CO2 readings, we can get a pretty good idea of how the body is functioning. Keeping an eye on these readings while observing the actual process can improve overall patient care and outcomes. When thinking about cardiac arrest, our mindset needs to be that 1. VTAC VFib is a survivable event. Number 2, asystole might be a survivable event. Number 3, we must provide perfect CPR to every qualified patient. Any rhythm, any nursing home patient, 3 a.m. asystole every single time until otherwise directed, and hold ourselves accountable when we fall short. Number 4, every airway must be secured. Number 5, all interventions must be given appropriately and documented thoroughly. To achieve this, disciplined behavior is necessary. An ancient philosopher said, out of every 100 men, 10 shouldn't be there. 80 are just targets. They're just going through the motions. 9 are the real fighters, and we are lucky to have them. But one is a warrior, and he will bring the others back. Only a few are willing to run towards emergencies, and the best of the best strive to perfect their craft. We're going to be discussing the latest trends in EMS resuscitation science. This includes high-quality CPR, pit crew or the team approach, passive oxygenation, and cardiocerebral resuscitation. High-quality CPR consists of the following components. Minimizing interruptions is the cornerstone of this practice. After a few rounds of CPR, the compressor can become fatigued and lean on the chest while providing compressions. This reduces the amount of blood that can refill into the heart. We must provide 2 inches of compressions each time. Too much or not enough will have the same result as not performing CPR at all. We need to resist the urge to rapidly squeeze the bag valve mask when providing ventilations. When the provider's own epinephrine kicks in, everything speeds up. We have to prevent hyperventilation so that the chest cavity will allow proper refill of the heart. When rotating compressors, a great technique to use is the hover hands technique. The replacement compressor gets into a position and their hands hover over the compressors. When the original compressor moves, there is little to no pause in compressions. A study conducted over a decade ago shows the undeniable truth. Pauses in compressions drastically decrease chances of survival. With pauses in compressions less than 3 seconds, there was a 100% survival rate. Less than 10 seconds, there was an 80% chance of survival. Less than 15 seconds, there was a survival rate of 40%. And anything greater than 15 to 20 seconds resulted in a very minimal survival rate. This evidence is true today. Pauses and compressions longer than 10 seconds cause a significant drop in survival. High-quality CPR is all about perfect compressions, minimizing pauses, defibrillation, and controlled ventilations. Everything else is secondary. The pit crew approach treats resuscitation like a pit crew tire change. The process is engineered, and each member of the team has a specific role or task. The downside to such a coordinated approach is that it requires significant resources. Due to the unpredictable nature of EMS, we do not know when help will be available. The lessons we can apply from the pit crew approach is improved teamwork and predetermined roles. These improve coordination and patient outcomes. Earlier, we discussed the dangers of hyperventilation and overinflation. We were all taught that ventilation equals oxygenation. Studies are finding that the mere presence of oxygen in the lung space can facilitate gas exchange without applying positive pressure. In some systems, using a nasal cannula at 10 to 15 liters per minute in an apneic patient will help provide oxygenation of the lung space, and the pressures created by proper chest compressions will facilitate gas exchange. The same technique can be used prior to intubation to decrease desaturation. Multiple agencies state that there is insufficient evidence for or against the practice of passive or apneic oxygenation. One truth has been constant, though. Positive pressure ventilations during VTAC and VFib arrests can be detrimental to survival. Cardiocerebral resuscitation takes the oxygenation a step further and promotes an apneic approach. The patient is placed on a non-rebreather mask at about 10 liters per minute, and continuous compressions are provided to reduce pauses. Cardiocerebral resuscitation teaches that there are 3 phases of cardiac arrest response. The first 5 minutes is the electrical phase. Defibrillation is found to be very effective during this phase when VTAC or VFib is present. The second phase is between 5 to 15 minutes, where compressions are needed prior to defibrillation. Without pre-shock compressions, asystole or PEA almost always results after defibrillation. The third phase is after 15 minutes, and where, without interventions prior to arrival, treatment is unlikely to be effective. Let's take a look at the rural Wisconsin CCR study. The focus was to reduce interruptions of chest compressions. Post-shock rhythm and pulse checks were eliminated, and initial airway management was limited to an OPA and supplemental oxygen. For witnessed arrest, ventilations and intubation was delayed until ROSC or 3 rounds of CPR were performed. In the 3 years prior to starting the study, there were 92 witnessed arrests with a neurologically intact survival rate of 15%. After implementing the protocol, they had 33 witnessed arrests with a neurologically intact survival rate of 48%. This gives more fuel to the argument that we must become better at reducing interruptions and compressions. The Arizona Minimal Interruption Compression Resuscitation Study focused efforts in 2 metropolitan cities and emphasized compressions and delayed intubation. Overall survival to discharge rose from 1.8% to 5.4%, and VTAC VFib arrest survival rates rose from 4.7% to 17.6%. Studies have also shown that adequate oxygen exists within the blood at least during the first 10 minutes of cardiac arrest. This adds to the evidence that circulation influences survival more than ventilation. Magazines, published studies, and even podcasts can help you keep up to date on the state of the science of EMS. One popular podcast is found on mcrit.org by Dr. Scott Weingart. He has a talk entitled, "The Laryngoscope is Potentially a Murder Weapon." This actually took some heat of being too critical of endotracheal intubation. But let's discuss the designation of this gold standard. Tracheal intubation has been used since the 1970s. It was deemed the gold standard, primarily due to a lack of a good blind insertion airway device or supraglottic airway device. We now have countless options for protecting the airway other than an ET tube. So why are we still employing 1970s tradition? Growing evidence suggests that tracheal intubation is not the optimal method of airway management by paramedics and may be detrimental to patient outcome. Initial training is also lacking, and attempts for students are not as readily available as they used to be. Supraglottic airway devices are a suitable alternative pre-hospital airway device for paramedics. Endotracheal intubation is still valuable in out-of-hospital cardiac arrest, but it falls low on the order of priority. Securing the airway without CPR interruption is far more important than intubating. During the first few test flights of large aircraft, things went horribly wrong. With so many dials and gauges to keep up with, many pilots were extremely overwhelmed. Enter the checklist. The checklist in aviation was an evolutionary step that helped large aircraft development and started the aviation industry as we know it. Checklists in healthcare are becoming more and more common. One study out of Johns Hopkins University showed an issue with infection rates on central line placements. These were reduced from 11% to almost 0% just using a checklist that reminded physicians to wash their hands and use sterile procedures. Could the doctors have remembered that on their own? Maybe. But the checklist ensured that they did it right every time. Introducing the MGA Cardiac Checklist. It's not a masterpiece or groundbreaking source of information, but it simply organizes the steps of a procedure and allows the user to check down through the steps to ensure a uniform outcome. So at the top we have the first 10 minutes of a cardiac arrest should be worked on scene. And we have an asterisk there because there's sometimes that we're hindered by limited workspace or dangerous scenes. One of our first items we should be doing prior to getting to the scene is establishing a game plan, knowing who will be in charge. I got the monitor, you do the airway. Are they pulseless? Let's begin compressions. If compressions are already in progress, don't stop the compressions until the pads are connected and you're ready to evaluate the rhythm. Remember, 2 minutes of CPR equals 200 compressions. The capnography circuit hooked up to the BVM and ventilations are controlled. And that's 30 to 2, or every 6 to 8 seconds, with an advanced airway in place. So we're not squeezing rapidly, we're giving nice controlled ventilations. Pause for analysis and charge monitor every 2 minutes, 5 seconds for rhythm identification, no longer than 10 seconds total for all other procedures, including minimizing the perishock pause. Immediately resume compressions and repeat the process every 2 minutes. With PEA, be sure to check for pulses or heart tones. This is often missed by doctors in the ER. We should be listening for these as well if we can't readily feel a pulse and we're thinking that there is a rhythm. Administer first round of 1 milligram, 1 in 10,000 epinephrine, IVIO. Repeat every other pause and compressions to a max of 3 milligrams. If VT or VF, consider antiarrhythmic therapy with amiodarone. That's 300 milligrams. Repeat at 150 milligrams after 2 rounds of CPR. Continue compressions and repeat the process every 2 minutes until ROSC or termination at the receiving facility. At the bottom there's a few notes. Advanced airway management or drug therapy should not significantly delay chest compressions or defibrillation. If ROSC is achieved, obtain a 12-lead EKG immediately and transmit to the receiving facility. A lot of patients that go into sudden cardiac arrest are a result of a massive cardiac event. Saving time and getting that patient directly to the cath lab can improve their outcome and survival. We must focus on outcomes, and these are some of the most important. Gaining ROSC, neurologically intact at discharge, able to resume the former standard of living. The question we always have to ask is, are we maximizing the patient's chance at survival? Let's go to one more study in Arizona. The Zoll Mesa, Arizona Fire Department's CPR Improvement project focused solely on providing the depth and proper rate of compressions. In addition, they limited interruptions, shortened their pre-shock pause, and delivered better ventilations. The initiative helped to double VTAC VFib out of hospital cardiac arrest neurologically intact survival. We have to focus on the basics, and it will result in better patient outcomes. Again, I refer to this very simple chart. We have to cut our pauses in CPR to no longer than 10 seconds if we want to have good patient outcomes. Remember the chain of survival? Early CPR is one of the links, or the circles. We need to own that circle. We need to own the resuscitation. I hope you will join me in striving for better patient outcomes through better CPR. Thank you. I appreciate everything that you do.